Thanks for the kind introduction, James, of course. It's an exciting event to be here. Thanks for the invitation, of course. It's a pleasure to be on this webinar and collaborating with University of Alberta. You mentioned it well, one of the premier CE providers across the country at this point. All the programs have been great. So it is truly an honor and very exciting to be working on this collaborative program with you guys on that one. Thanks for the kind intro, of course. That was lovely. I will take the lead, I guess, on this one, Michael, and we'll go on. I thought it would be nice kind of tonight to start talking about why should we even talk about sleep. I know most people that are here are probably excited. They're probably passionate. They know why we want to be talking about sleep. But for some of you who are not, perhaps have been exposed to the topic in the past, I want to spend about 15, 20 minutes just talking about the importance of sleep, both from the medical aspect and also how it impacts our dental treatments and dentistry in general. I noticed there's a lot of hygienists on the call with us. That is fantastic. I really strongly believe the hygienists can be the lead providers, healthcare providers in this area of medicine and dentistry. So very exciting to see that high number of hygienists on the call today. And of course, our general colleagues. Thank you all for being on the call, of course, with us. Again, a pleasure to be presenting with you guys and having some Q&A time. We will talk about the program a little bit towards the end, and perhaps we'll have some Q&A and we can answer any questions that we didn't cover in the presentation. With that being said, I'm just going to share my screen here and just let me know if there is any technical difficulties. That's the beauty of Zoom. When it works really well, and when it doesn't, it's a disaster, right? So can you guys see the presentation right now? Perfect. I'm getting a thumbs up here. So let's just get us started without wasting any time. I want to talk about basically the kind of society that we live in today. We all understand that we live in a very, very busy society. There's so much to do, so little time. I feel like in the past 3, 4, 5 decades, this is probably the busiest decade that we've all lived in. So much to do from work-wise, social media, everything, and there's so little time. And when you start looking at that, there's no surprise to start looking at it and realizing 35% of the population are sleep deprived today. Based on the data that comes from the National Sleep Foundation, we know over 1/3 of the population today, this is in North America, and of course it kind of extrapolates around the whole world as well, happen to be sleep deprived. And if you kind of compare ourselves to our ancestors from 100 years ago, right around that 1920s until now, we tend to sleep about 2 hours or less per night. We used to sleep about 9 hours per night. And now in the 21st century, the average many hours of sleep that people are sleeping is about 6.8 hours or less. And when we look at the surveys that has been done, again, through the National Sleep Foundation, we only know about 10% of the population prioritizes sleep over other activities. What do we mean by other activities? So when they looked at a sample population, sleep came fourth in terms of prioritization. What came first was, of course, socializing with family and friends, which I understand, tending to the hobbies, and number 3 was actually working. Working came higher than sleep in terms of prioritizing. So it's kind of interesting because you start wondering, okay, what is this big deal about sleep anyway, right? You know, we spend about 1/3 of our lives is sleeping. That's a lot of time. So there should be something important about this physiological process that we require about 1/3 of our total lifetime doing it. Well, we all understand sleep is important. It's important for our mental health. It's important for our physical health. A lot of our restorative processes, physiological processes, repair process happens while we're sleeping. In terms of our psychological health, a lot of our memory consolidation, a lot of our learning, a lot of new circuitry formation happens while we're sleeping. But the impact of sleep goes beyond that. So when you start looking at the research and what is available out there, you start realizing sleep actually impacts every pillar of our health. So when you look at the concept of total health, which is something that is getting more attention in today's world, there is 4 pillars to total health. It's your physical health, mental health, it's your work and occupational health, and it's your personal life health in general. What is the balance? And the concept of total health is you're looking at a balance between all those elements. So when we start looking at sleep, what we do know is lack of sleep, whether it is a sleep restriction, or it is due to sleep interruption because of a sleep disorder, such as a sleep apnea or any other sleep disorders. As a matter of fact, there is another 84 sleep disorders out there, sleep apnea being one of them, and obstructive sleep apnea being just a portion of that. What we've learned is lack of sleep is going to be impacting us in many different aspects of our health. For instance, when you start looking at physical health, we knew people that have a sleep apnea, they have about 23 times more risk of having heart attack and cardiovascular events. How does that compare to smoking or high blood pressure? People with high blood pressure, smoking, they tend to have about 11 and 8 times more risk of having heart attacks. People with sleep apnea tend to have 200% increase in risk of having cerebrovascular, basically nighttime strokes. There is about 70 to 80% correlation between sleep apnea and diabetes. As a matter of fact, now a lot of the treatments that happens for diabetic patients, one of the most foundational thing that happens is doing a sleep apnea testing, because we understand it is very difficult to manage the disease without managing their sleep apnea. And of course, lack of sleep happens to impact our fitness and BMI. We understand a lot about that. Actually gaining weight because of a sleep apnea is a concept that has been researched really well. But the impact goes beyond just physical health. It actually impacts our mental health. There is a big correlation between depression, anxiety, and sleep apnea. A lot of it relates to the amount of stress that the body goes through throughout the nighttime. So people that have a sleep apnea, they tend to have very high cortisol levels during the nighttime, which is your stress hormone. And that's why when they wake up, they feel very anxious and the stress level goes high. We also understand big correlation between sleep apnea and Alzheimer's disease and dementia. Our memory consolidation, as I explained, happens when anything that we learn goes from our volatile part of our brain to the non-volatile part of our brain when we go to sleep. So we don't get that proper sleep architecture because of a sleep apnea. That memory consolidation does not happen as easy. And also, a lot of times when we're sleeping, the way the brain gets rid of any kind of byproducts, any noxious byproducts that develops throughout our daytime, it happens while we go through our deep stage of sleep. These are proteins called beta amyloids. And if you don't get enough sleep, even 1 hour of reduction in sleep correlates to increased level of beta amyloids in our brain, which directly correlates with Alzheimer's disease. So we know lack of sleep, for instance, and sleep apnea impacts every part of our mental health. There are studies and also research shows that increased risk of errors and stress, and even correlation between proper sleep and income level and how it impacts our occupation in general. And I can go on, and most importantly, how it impacts our personal lives, right? We know people with a sleep apnea tend to have 10 to 15 years shorter life expectancy compared to a lot of other people, if it's left untreated, of course. It impacts people's relationship. That's one of the things that mostly patients will come into us and ask for help. It's snoring. Number one reasons in North America for couples to be sleeping in separate bedroom happens to be snoring. It does impact our sexual health and social life in general. So I can go on and on and on and on. But by now you understand sleep is more than just laying in bed and resting for 7 or 8 hours per night. It is the foundation of our total health. It is something that impacts everything that we do. So not only in terms of helping our patients, but also even in terms of our own personal health, it is very important to take sleep seriously and actually prioritize it on top of everything else. Because by prioritizing the sleep, we learn that every other aspect of our life is going to improve in a sense as well. But the impact of sleep goes beyond just our general physical and medical health. It impacts dentistry a lot more directly than some of us might have known. And as a matter of fact, when I look at the research for the past 10 to 15 years, we realize the correlation between sleep and dentistry is a lot closer. And what I'm talking about here is not about what dentistry can do for patients with a sleep apnea, because we go into a lot of courses, we go to a lot of webinars, and people are talking about the role of dentistry in sleep, which relates to providing treatment, which we'll talk about briefly as well. I'm actually talking about the role of sleep in dentistry. How does sleep apnea and sleep disorders impact our everyday dentistry? We're talking about fillings, we're talking about crowns, we're talking about bruxism, we're talking about periodontal disease. These are the things that we strive to do our best on day-to-day dentistry. And now the research is showing sleep is going to be impacting every one of those aspects of dentistry if it's left untreated sleep apnea. So let me go into details a little bit. Bruxism and sleep. We know there is about 70 to 80% correlation between bruxism and sleep apnea. So if you see a patient with bruxism, there is 70 to 80% chance that they might have some sleep disorder breathing problems. What does that mean? That means that before we decide whether or not we want to put a 2mm upper hard balance splint or whatever else type of a splint that you use, we have to understand what is the underlying cause. Because if we ignore that, there are studies that actually show by giving a 2mm upper balance splint, you can actually worsen sleep apnea in half of these patients by almost 50%. So looking at the underlying cause, it's very, very important. I'm sure most of us had the experience that we provide an upper 2mm splint for a patient comes back 2 weeks later and they're telling us what? I don't like wearing this device. It makes me snore more. I feel like I'm choking on it. And they're not lying to us. They're actually telling us the truth. It actually encroaching into their airway even more and making the underlying cause even worse than what it initially was. How about periodontal disease? For all the hygienists that are on the call with us, as I said, I really believe hygienists can play a leading role in this area of dentistry and medicine. What we understand now is periodontal disease and obstructive sleep apnea is very, very closely correlated in that sense. Why is that? When we look at a sleep apnea is basically a chronic low inflammatory chronic disease. So it creates systemic inflammation in the body. When patients have a sleep apnea, when you look at their inflammatory markers such as interleukin 6, interleukin 8, C-reactive proteins, they tend to have higher serum levels of those inflammatory markers, which are the same inflammatory markers that we see in periodontal disease. The studies have shown it's very, very hard to manage periodontal disease in sleep apnea patients if we're not managing their sleep apnea, which totally makes sense. We're going in there doing as much local debridement as we want to do. We're creating that local, proper, healthy environment for proper periodontal health, but there is a systemic inflammation that is going on. So we're kind of fighting that losing battle in a sense. Doesn't matter how much we manage that local inflammation. If their body is going through systemic inflammation, it's going to be very hard to get proper periodontal prognosis in these cases. Of course, there is a big correlation between airway and orthodontics and pediatrics, so I'm not going to go into details with that. My colleague, Dr. Major, is going to be covering that in detail. And now in the recent years, we're actually learning that there is even more implant failures in patients with sleep apnea. What does that mean? That means that if you have a patient and they have obstructive sleep apnea, before we go in there and try to treatment plan a bunch of implants for them, we start having to pay attention and telling them, hey, your sleep apnea is a risk factor for the prognosis of these restorations. It either needs to be addressed and treated prior to us going further into these treatment plans as part of comprehensive dentistry, or we at least have to let the patient know about such risk factors. TMD and pain, of course, big correlation going back to the bruxism. There is about 50 to 70% correlation between these TMD patients and sleep apnea patients, and also patients that dealing with chronic pain. People with a sleep apnea tend to have lower and smaller level of REM sleep, and lack of REM creates a problem called hyperalgesia, which means that simply higher perception of pain. So we're trying to manage their pain, we're trying to manage their inflammation in their TMD patients and these pain patients, but while we're ignoring their sleep apnea, which causes pain and causes inflammation. So what I'm trying to get at here is the correlation between dentistry and sleep goes beyond just simply dentistry providing an appliance for these patients and giving them a solution. It actually is very important to realize that it is part of dentistry right now. It's one of the pillars of dentistry that we look at. If we ignore these sleep problems, it is going to impact every part of our general comprehensive treatment planning. The research is very clear on that one. It doesn't mean that we have to treat everybody. It doesn't mean that every dentist should be trained in treating sleep apnea. It simply means once you're doing your comprehensive treatment planning, you must look at their sleep and airway assessment and put that into consideration when you're coming up with a treatment plan. Well, the problem goes beyond that. I feel like by now everybody understands, well, here it is, it's important, I need to know more about it. But there is a big public health problem out there. There's over 1 billion people worldwide that have a sleep apnea today. Some of us might know that, some of us may have not known that, but it is a big, speaking of pandemics, and the one that we were kind of in the middle of it is still not over. Some people consider sleep disorder breathing a pandemic. There is over 1 billion people, and over 80% of these people still remain undiagnosed. That is the problem. That means that they're walking through our clinics not even knowing if they have a sleep apnea or not. And it is our job as healthcare professionals to actually be able to identify them. And that's what we'll be covering through the actual courses that Michael will be talking about. Will be very easy to identify, at least let these people know that there is help available for them. So what is a sleep apnea? Let's talk about that simply. Sleep apnea happens when our airway, basically the tissue in upper pharyngeal airway, which is a little bit more collapsible, collapses while we're sleeping. It doesn't happen during the daytime, mostly because our musculature, our neuromuscular compensation keeps our airway open. It basically counteracts that negative pressure that is being caused because of the respiratory physiology and maintains the airway open. But when we go into sleep, especially when we go into REM sleep, we get paralysis of all these muscles except our diaphragm and intercostal muscles, and that is when we get into trouble. So we get a narrowing of the airway, and you got to keep in mind this narrowing is not just a two-dimensional narrowing. It's not like our tongue just simply falls back. It basically is a collapse in any direction. It could be a lateral direction. It could be an anterior posterior direction. It could be what we call a concentric circular collapse. So it is a lot more complicated than just simply our tongue falling back. We use that a lot for our patients to explain it, but it is a more complex disease. For instance, here we can take a look at a patient that we're doing endoscopy while they're under sedation. It's called drug-induced sleep endoscopy. And we can take a look right here. You can take a look at their epiglottis, and we can take a look their tongue is actually maintaining the airway really well. It's the lateral parts of the wall, the airway, upper pharyngeal airway, that is collapsing in. So it is very important, that pattern of the collapse and the level of the collapse, which tells us, okay, whether or not, for instance, an appliance is going to work for the patient. The problem goes beyond just anatomy. There is a lot of other factors that impacts what kind of a sleep apnea and how severe their sleep apnea is. Of course, we're not going to go into details. It has to do with what we call your loop gain, your stability of your breathing centers, your lung function, your basically the activity of the pharyngeal dilator muscle. Anatomy happens to be one of those things, your arousal threshold. So there is a lot of physiology that goes beyond these patients that have a sleep apnea. Some of them, as a matter of fact, they have a perfect anatomy. It's a very collapsible anatomy at nighttime. So what I'm trying to get at here, it's not a very simple disease. It's not a very simple collapse, but there are solutions. There are treatment options. What are the treatment options? CPAP, oral appliances, surgical treatments, what we call behavioral strategies, which is such as weight loss, not drinking, and not smoking, and factors that would, again, impact the inflammation level of your body. Anything that increases inflammation is going to be impacting your sleep apnea in general. The most common treatment for sleep apnea happens to be CPAP, which is what we call it the dreaded mask. As much as it's dreaded, it has saved millions of lives, and up to this day, it still is considered the gold standard. Why? Because once you put it on a patient, it works. The only problem is people don't like wearing it. Only about 50% of people that go on a CPAP tend to remain compliant with the treatment. That is why we need alternatives. And what are the alternatives? The alternatives happen to be oral appliances. Very convenient, very small. These are custom fitted, adjustable appliances that are going to basically reposition, not necessarily advancing the mandible. What we've learned is just by repositioning and stabilizing the mandible, your lower jaw in the right position, we can keep these patients' airway open. And it works in a lot of patients, not everybody. We will talk about that. And these devices happen to be very comfortable, very convenient, easy for traveling. Patients tend to tolerate them more. Well, some of you might be asking them, why don't we see more of these appliances out there? Well, we get complete response in about 60 to 70% of patients. So if you make oral appliances for every patient out there that has a sleep apnea, it works in about 60 to 70%, as opposed to the 100% that we saw in CPAP. It is preferred by most patients, but surprisingly, it only accounts for 5% of the treatment today, which means that almost we can have 10 times more patients benefiting from such a great treatment, which works as good as CPAP in those 60 to 70% of the population, but we're only getting 5%. So why is that? Well, they come with problems. Of course, aside, we have side effects. We got changes in the occlusion. We got changes in teeth movement. There are problems in terms of running the practice, communication with physician, but most importantly, not knowing which patients are going to for sure respond and at what level of protrusion, at what position of the mandible. There are a lot of challenges, but these challenges have been addressed a lot in the past 10 years. And these are some of the things that we will be covering in the course, in the program that we're putting together in collaboration with the university, and being able to help everybody, being able to provide this therapy in a very confident manner. So there is a lot less guesswork into it, and there is more confidence, and there is less of a trial and error model, which we unfortunately have seen in the previous decades when it came to oral appliance therapy. It's one of my favorite quotes. Is if you can't explain it simply, you don't understand it well enough. And I feel like that was a sleep medicine perhaps 10 years ago. We did a lot of trial and errors, or even 20 years ago. And we came up with a lot of hypotheses, a lot of different ideas, but it was simply because of lack of understanding and lack of research. As we look at the last 10 years, we have a lot more knowledge in this area, so we can simplify it. So every general dentist, in a sense, can get involved into this, again, growing and important part of dentistry, in my opinion, and help, most importantly, a lot of patients that are in need. Again, I'm going to go back to that 1 billion people that have a sleep apnea. That means that tonight, 1 billion people, when they go to sleep, they're going to stop breathing. And about 800 million of them don't even know that's happening to them. And that's something that is going to shorten their lives a lot. And as dentists, as dental professionals, as hygienists, as assistant, we have the ability to go there and not only help them live a better life, but also live a longer life. So it's a big responsibility on us, in a sense. That's how I look at it, of course. What is the key? What do we need to do? And this is going to be the focus of the program, is, of course, treatment planning. When you look at prior to last decade, there was a lot of discussions about just simply making an appliance, and what I call the prep and pray model. It means that you would prep it and you would pray that it works, courtesy of one of my friends that taught me that. And that's what we look at. We want to kind of take a look, and we want to take that guesswork out of it. So key is actually spending time on treatment planning, understanding these patients, working on case selection, knowing which cases are going to be simple cases, which cases are going to be complex cases, and starting with cases that fits within our scope of clinical expertise and clinical practice. And we will cover that. We'll go through that a lot in the program, but this is not going to be a program just simply about what is a sleep apnea and how to make appliances. This is about what is a sleep apnea, when can we make appliances, and what are other treatment options? How do you triaging these patients? And it is very important to create a multidisciplinary model, which I know Michael, Dr. Major, is going to be talking about that quite a bit. And also, we're going to be going in depth in terms of other, what I like to call, pillars of success when it comes to anything in the industry. It's beyond just clinical skills. For any new treatment that we want to incorporate into our clinical practice, you can be the best dentist, but it doesn't necessarily mean it is going to be a successful part of your practice if you don't have all these three pillars perfectly addressed, in a sense. Clinical skills, we'll learn it through the course, but communication skills, how to talk to the patients, how to bring up these problems, how to discuss treatment options, how to even do the consultation, and how to motivate them and guide them to go ahead with a treatment that is going to be helping them live a better life. We'll talk about all that. Organizational skills. How do you create that multidisciplinary model? How do you start collaborating with other professionals in the area? How do you create a sleep team within your practice? These are the things that are extremely important. And some of you might be wondering, why is it important? Well, if you cannot create a successful sleep program, at the end of the day, we're not going to be helping enough patients. And if we're addressing all these three things, that's when we can have the most impact on our patients' lives from that perspective. So I'm going to kind of end it here because I know there is a lot of topics. I know this was very, very quick. I just wanted to give a simple overview of why everybody should be looking at learning about sleep in general, because the impact of it is beyond just making appliances. I know I said that many times. We can actually save people's life. It's not about just simply changing people's life. It is an opportunity for us. We've always believed dentistry is part of healthcare, but here we go. Here is an opportunity for us to actually go and impact millions, tens of millions, hundreds of millions of people's lives, for them to live a healthier life, better life, and a longer life. And I feel blessed as a dental professional for, number one, being able to provide this kind of treatment for our patient. There's not many professions out there that would allow you to save a person's life, truly. And when I say dental professional, again, I'm talking about dentists, hygienists, and dental assistants, and everybody that is involved in this team that is going to help us create that impact. And also feeling blessed that I will be able to share some of that with you, my colleagues and great friends here, and truly feeling honored about that one. So with great power comes great responsibility, which means that now that we have that power in our hands, it is on us to actually go ahead and implement it in place. With that being said, I'm going to end it here. I'll be here for any questions later. Hopefully I didn't take too much time there, James. You told me to kind of keep it brief, but I don't know if I could have made it any shorter than that.
Well, that was perfect. In the Q&A section, do you want to handle that that one that was lobbed out by Lois? Once treated, is life expectancy and all the other aspects of our lives back to normal?
Can we go back to the questions at the end? I think that would be great, because
sure.
I want to give Michael and everybody, if that's okay.
Yeah, I'm good by that. Or the other thing we can do is you can respond to the entire group within the chat side of it as well. So that, and it's almost like having two conversations. So I'm good with that. But yeah, I mean, I can see where this stuff's going to start spinning a whole bunch of questions, and we want to encourage that as well. So for the participants. But yeah, I agree. Michael, you know what? Let's keep it rolling.
All right. Sounds good to me. Is everything coming through nicely on your end here?
Perfect.
Perfect. All right. Let's see if we can get this screen share running now. There we go. Good. Okay. Well, again, thank you for the introductions, James. It's a wonderful opportunity to share with everybody what is certainly a passion for my practice, and to be able to share this information with some wonderful colleagues like Suresh and with Enoch. What we're going to be, let me get this out of the way. I'm going to be running through just a little bit on the pediatric side. The goal here is to provide a high-level overview to give a sense of what to expect in the courses to come. It's not to go into a tremendous amount of depth, although we certainly will answer questions as they come up. So let's get going. What we're going to be doing is looking at three general high-level items as they really relate to everyday dental practices. How often are you going to see this in your practice? What's the difference between adults and children, especially after we've now heard this really great review about adults? And what happens if we do not address the problem in children? So the first question is really about prevalence. And the question that we have to ask ourselves is, how big of a problem is this? How many people are we going to see in our practices on a daily, weekly, monthly basis that we can expect that we should be able to identify a problem? Now, it's not an entirely clear answer, sadly, and it goes into the nuances that as we go through the deeper layers of the course will make more sense about how you define a sleep problem. What exactly is sleep apnea? What is the threshold that requires help, intervention, that we can say there's a real diagnosis of a problem? But if you look at that really technical definition of obstructive sleep apnea, the numbers that are used most commonly is it's about somewhere around 5% of children have obstructive sleep apnea. Now keep in mind, this is a very, very technical definition about how much a person would stop breathing, how much the oxygen levels drop, and it negates a lot of the other nuances. So that when you go to some of those more outlier studies that use a broader definition of a sleep problem in children, that number can go from, say, 5% and jump all the way up to 25%. Keep in mind that the data that's being referenced here is also data that is probably about 10 years old in publication, which then dates back to information that was published maybe 10 years prior before that. And over the last 20 years, we've seen a lot of the risk factors increase for pediatric sleep apnea. In my own clinical experience with the patients I see, my numbers are higher than 5%. Part of that is because of the referrals I receive, but I also think that just like adults, it's a severely underdiagnosed problem. But if we work with those numbers and we say that the numbers are, say, 2 to 5%, and that in average clinical practice in general dentistry that you maybe will see 30 to 35 kids in a month, then it works out that you would expect to find at least 1 to 2 children every single month that you should be sending and identifying as there's a sleep concern here that needs to have further follow-up and assessment. But if the numbers hold true that it's closer to, say, 12% to even a quarter of your patients, now all of a sudden we're looking at 4 to 7 kids every month coming through the practice, sitting in your chair, that you have a massive opportunity, not just to help with their dental health, but to help with the overall health physically, systemically, and to set them up for a lifetime of success. Because in my mind, even if we say conservatively 3 to 5 kids a month in an average practice, that's still a lot of kids that are available for us to help. Now, there's a lot that's being talked about in different circles, that there's somehow a difference between pediatric sleep apnea and adult sleep apnea. When Dr. Charkandi and I were developing the sleep apnea guidelines for the province, the physicians that were on our team were very clear and wanted us to be really a central part that they wanted communicated with our dental colleagues, is that sleep apnea is one disease. Whether it's showing up in children or whether it's present in adults, it's really the same disease. What is happening in any sleep apnea condition is you're not getting enough oxygen into the blood when you sleep. For one reason or another, that proper level of perfusion, the air we need getting into our body is just not happening, which then creates an entire downstream effect, both of the physiology and the well-being mentally and physically. Now, when we think about what's happening, the underlying premise of any sleep condition, whether it's in a child or whether it's an adult, is that you have an obstructive event. Somewhere, somehow, for whatever reason, the air is not flowing through the nose and through the mouth and into the lungs, or it's getting through in a limited amount that's not enough for the body to be able to manage what it needs to do to keep your body oxygenated to do what it needs to do, just the normal breathing and the movement or whatever else you might need to maintain proper physiology while you're asleep. When you don't get enough oxygen, there's a predictable sequence of events that begins to happen in the body. That obstruction, or creating a lower amount of oxygen, creates a condition called hypoxemia, basically meaning you don't have enough oxygen, which then changes the body's overall chemistry balance so that we have more inflammation that creates as a result. And it's from this launch point of recognizing that the obstructive event then leads to increased inflammation that we can have a much better foundation to look at what are the comorbidities, what kind of diseases are we going to see that sleep is going to affect in dentistry, in overall well health, what kind of medical history in our patients that are coming through every day. Are the patients who are at higher risk for having sleep apnea? Which of our patients, if we address the sleep apnea, we can expect to see other health problems likely to improve as well, because of the connection and the linkage that when you have an obstructive problem, it leads to higher amounts of inflammation in the body. Now, in adults, we see a lot of these chronic inflammatory conditions show up as things like diabetes or hypertension, cardiovascular disease, obesity. And if we're looking at longer term for what happens when you're not sleeping properly, depression becomes a part of these things as well. They're disease clusters. They're things that occur commonly, and the linkage between all of the problems is inflammation. Now, if we look at children, on the other hand, it's the same underlying physiology. We have obstructive hypoxic events leading to more inflammation, but the disease clusters, how they show up, is a little bit different. We have asthma, eczema. We have these changes in facial growth. Obesity is still there with children too, and it's becoming more and more of a problem. And the psychological problems, the mental health issues that children face, are more on the attention deficit side than on the depression side. But the real question, especially when we're looking at children, is, well, what's the long-term consequence? For adults, we know that one of the consequences, for example, is potential death. And anybody who's been in dental sleep medicine long enough will know and will have experienced, sadly, where you have an appliance ready to go for a patient, where you've seen them, and before you get the opportunity to care for them, that they're going to pass away of an OSA-related problem. Now, thankfully, in my area of practice with children, children's physiology has not been so taxed and compromised that death is really an issue. But instead, the children face is the possibility of that what happens now is going to affect and have a ripple effect that's going to last for the rest of their life. And those ripple effects can show up physically, they can show up in their mental health, they also show up in their dental health. When we're looking at children and the effects on their overall physical health, one place that's have a more severe consequence is the cardiovascular health. High blood pressure, while a problem in adults, can also become a problem in children. Now, you don't have the same atherosclerosis issues in children that the way you would have in adults, but when you have children who have prolonged, chronic, high levels of blood pressure, the body can respond by having the heart become much more hypertrophic. That heart muscle becomes bigger and stronger to try to overcome the pressure, which then can create a condition called cor pulmonale. Now, this is a rarer, more severe problem that a child can face, but it is one of the potential consequences. What sits more though, however, especially with kids, is all of the levels of inflammatory disease. The asthma, the allergies, the runny noses, these are the things that are typically seen. But what we're beginning to see more and more and more is that as obesity becomes a bigger and larger problem with children, that more and more adult-like disease presentation is showing up in children as well, including things like type 2 diabetes in children, including things like a more adult-like presentation of hypertension. What might be more directly, especially to what my practicing profession orthodontics is the way that that sleep apnea affects growth. Now, there's the big picture growth that children who have sleep apnea tend to be of a shorter stature, both in height and overall body structure. But there's then the next layer too, which is about what happens with the craniofacial growth. That there is a definite and direct impact of when we don't sleep properly, that we don't grow properly. What you'll find in some of our layers of courses is some of the beginning stages is really understanding what does normal sleep look like, so that when you see how normal sleep is interrupted, it makes a lot more sense why you would see some of the side effects you would. So for example, what we know is that growth hormone is released in the deeper sleep stages and points of sleep. It's the reason why we get better physiologic repair and recovery in adults. It's also the reason why children tend to be underdeveloped in their height and in their stature if they don't get a proper and deep night's sleep. If we continue along and move from the physical and now look at the mental, there are significant mental health results from untreated sleep apnea in children. The first one is depression. Now, this is very common in adults and it's less common in kids, but it's definitely there too, and it's been coming out more and more in the research as of late. The more common problem is attention deficit disorders. Now, I use the picture on the side here because anybody who is on this call and who has children would know if your child wakes up in the morning looking like this little guy is looking, you know it's going to be a really tough day. You know that he didn't sleep well. You know that his attention is going to be short. He's not going to listen very well. He's going to be running around at Mach 10 with his hair on fire. These are the hallmark characteristics of attention deficit disorder. When we think of adults with sleep problems, when we get tired, we get down. When we get tired, if we think about it, even for ourselves, if you haven't slept for 3 or 4 nights and don't have sleep apnea problems, you feel less motivated, you feel less energy, you feel lethargic, you feel a little bit down about life. When you do that long enough, that becomes depression. Children, on the other hand, when they get tired, they become tired and wired. And that tired and wired and the inability to sit still, to have focus and attention, it looks exactly like attention deficit disorders. Now, when you have a child who's either not feeling well about themselves or who can't focus, the very natural result is that children are not going to do well in school, leading to poor academic performance, which, as all of us know, is going to have profound lifelong consequences. But I think even more than just the academic performance, when you have a child who has attention deficit and they're running around and they're always getting in trouble with their parents, when they're not doing so well in school and they're feeling the challenge and watching their peers go past them, eventually what will happen is a child will begin on this identity of I'm dumb and I'm stupid. And it's that limiting self-belief that a child can begin to take on that would haunt them like a ghost for the rest of their life, even as they can address the physical and potentially even directly attention deficit issues. That identity and the self-esteem problems that can haunt them for forever are very deeply entrenched, all potentially resulting back from the lack of sleep. So we've looked at physical health, we've looked at mental health results from not treating sleep apnea in children. Let's look at oral health, because this now sits inside of our wheelhouse as dentists. The first and obvious one is malocclusion. Now, because thank you to Napoleon Dynamite, all of us know what adenoid facies look like, with a long face that's narrow and a constricted maxilla, tendency towards crossbite, potentially anterior open bite. But the reality is that the science is very clear. Children who have sleep apnea are much higher risk of having orthodontic malocclusion problems. Specifically, that tendency towards a retrusive chin and anterior open bite, class 2 malocclusion, and constricted maxilla. But because sleep apnea is an inflammatory problem, we do have a much higher risk of periodontal disease too. Now, we may not see gums and teeth that look like this in children, but when we look at kids with sleep problems, especially in orthodontics, this becomes a much more common issue. that we see a lot more gingival hypertrophy, that when that hypertrophy is starting to encroach on brackets, and for example, orthodontic patients, the likelihood of decalcification or caries becomes a much greater risk. But when we look at another even more profound level, what we know is that if you think about TMD now, and you're looking at degenerative joint diseases specifically, there's a certain facial phenotype that is more likely to have degenerative joint problems, and that is the same class 2 tendency, high angle mandible, anterior open bite tendency. And it makes complete sense that when you have this chronic inflammatory condition, at any point in time, like osteoporosis, for example, you have chronic inflammation, the bones begin to degenerate. Now, when you have chronic inflammation in the face and the head, it makes sense now that you could potentially have degeneration of the jaw joint problems. And so when you see a child like you're seeing here, this is a common presentation for sleep apnea. But this girl, while she also had sleep apnea, also had already, as a young teen, degenerative joint changes with the noticeable beaking happening in her condyles. But potentially even the bigger issue is the lifetime accumulated risks. We know when a child has an individual has sleep apnea as a child, that the likelihood of them developing another sleep problem as an adult becomes exponentially higher. We know that the family history of having an issue in the past becomes higher. We know that when you have challenges in school and you don't achieve your full potential, it has a lifelong consequence. The reason why it's so crucial in my mind to be identifying these problems in children is that while it may not cause an immediate risk to their life in terms of them dying, it has a longer term consequence that could haunt them for as long as they will be on this planet. You see, in my mind, I really truly believe, we think about dentistry, that we really see dentistry, the core center of our competency in dentistry is restorative dentistry. Whether we're talking about fillings or we're talking about crown and bridge or dentures, that is the central hub of most of dental practice. But surrounding and important to dental practice as core competencies is the surgical aspects of dentistry, for example, whether we're doing wisdom teeth extractions, if we're doing periodontal surgeries, if we're placing implants. These are crucially core competencies in dentistry. There's the other specialty aspects, whether it's endo or ortho, pathology and oral medicine, that are core competencies of where we are in dentistry. There's TMD is a core competency. You can't get through dental school without knowing these things. Well, as both what we've talked about on the pediatric side and also what Dr. Cherkande spoke about on the adult side, in my opinion, dental sleep medicine is now beginning to emerge to a place where we must begin to consider sleep medicine as a core competency to dental practice. Not only because of the overall health and well-being of the patients that we see every day and the way that as dentists we are oral health care providers, but also the fact that if you have a sleep medicine problem, that the prognosis of implants, the prognosis of full mouth reconstructions, the prognosis of orthodontic treatment becomes massively diminished if we do not address the underlying sleep problem first. It's with this kind of thinking is why our college began the process of creating a standard of care for dental sleep medicine in our province. And I believe the fact that we have the standard of care is a reflection of the fact that dental sleep medicine has truly becoming a core competency. Dr. Ng will be looking and digging deeper into that, into the guidelines specifically, but I also want now, as you've got this overview, and I hope that between myself and Dr. Cherkande that we've convinced you that dental sleep medicine is crucially important for your practice and for your patients, to give you a sense of what to expect for the courses that we have in the works. We have a multi-level course that we will be eventually offering. And the first level really is an introduction to dental sleep medicine 101. That our goal inside of that first level of a course is to have all attendees be able to leave being able to confidently and accurately identify, triage, refer their patients that they identify in practice. In addition, between just that identification and referral process, the ability to be able to stand alongside and encourage the patients in a meaningful and evidence-based kind of way so that we can give them direction and support inside of our practice for our patients who are undergoing one therapy, whether it's CPAP or whether they're undergoing oral appliance therapy. As we go deeper in, the next layer is a certification layer that would be coming from the program that would meet the standard, hopefully towards the college, of what would be necessary to practice dental sleep medicine in Alberta. And really then the goal becomes that as a dentist, you could successfully provide oral appliance therapy for a simple patient in a dental practice. Now, by simple, I mean a reasonably healthy patient. You want to make sure that you're not biting off more than you can chew. If you're starting to look at patients with, for example, severe asthma or COPD, these are patients that for your own well-being and your ability to sleep at night without too much stress, you don't want to treat them. You want to make sure they're referred along. And so case selection becomes an important part to make sure that you're standing at that higher standard of care for your patients and on side with the college. And so that becomes the goal of going through the certification program, that you would be able to come even into clinic, be able to go through the process of fabricating an appliance and through to delivery of an appliance as well. For those who find a tremendous amount of interest, we then would have a third level where we're really going into the advanced dental sleep medicine techniques. Now we're beginning to look at how do you practice inside of a multidisciplinary team that may include psychologists, that may include surgeons, that may include ENTs, that may include pulmonologists, so that you could do things like, you wouldn't do the CPAP therapy, but you may work with the pulmonologist to provide combination therapies. You may be then providing oral appliances for a responding patient who has a much more complex medical history. But this is a higher standard of care that requires a much stronger understanding of the foundations and the ability to work within a larger context of a team on a very routine basis. Finally, independent of a level 3, running parallel really to a level 3 is a course looking at the dental management of children with sleep apnea. This is much more of a craniofacial therapy. So this is, we could say orthodontic therapy, but in a much more targeted way that's looking at the growth and development using orthopedic techniques and altering the growth of the craniofacial complex. Learning that there's a case selection process that allows a higher degree of predictability than simply throwing, for example, an expander in every child that we think might have an airway problem. But the next layer, whether you're looking at children or adults, pardon me, is really the need to be able to practice within a larger group of a team. It's never ever just one problem when you're dealing with the complex adults. It's never ever just one problem when you're dealing with children. The ability to recognize what those problems are and how what the dental issue I'm looking at relates back to the medical history, that association and cross-linking between the malocclusion and the medical history, and be able to go back and forth between those two worlds is crucial, whether dealing with pediatrics or we're dealing with medically complex adults. And so the goal is to say, as you as a potential person looking as interest in this course, it's really up to you to know how far you could go. In my mind, level 1 is something as a standard of care that every single dental provider, whether they're a dentist or a hygienist, should really have a foundational level of knowledge so that we can provide our patients the higher standards of care. From there, it's really a choice and opinion as to whether you want to envelop this as a part of your practice. And if you do, then there's a pathway to walk forward to really make sure that you're providing that high level of care. And on that note, I am going to hand over to Dr. Ng, who can then speak with us a little bit more about what some of the guidelines are with the ADA&C and the standard of care with obstructive sleep apnea.
Hey guys, I'm not on mute anymore, right?
You're good.
Okay. Sorry I'm late to the show. I got held up a little bit. All right, can everybody see this? Awesome, thanks, Rex. Okay, so I'm not sure how many of you are aware, but as of 2019, the Alberta Dental Association College released standards of practice for any form of sleep disordered breathing treatment. I know a lot of what we've covered so far has been related to specifically obstructive sleep apnea and then craniofacial and oral appliance therapy for adults and kids. But understand that these standards of practice are for everything from snoring all the way up to sleep apnea. You can find this document on the ADA&C website. Inside the members section, it is non-surgical management of sleep disordered breathing. We'll start with this. What does this encompass? And right at the very beginning, it says sleep disordered breathing, broad term, everything from sleep apnea and any of the respiratory things associated with it, all the way down to snoring. So if you're providing treatment for just snoring, don't think that this doesn't apply to you. It certainly does, and we the college has been quite clear about that. Be aware that the college has required us to work as a multidisciplinary approach. That is not limited to just pediatrics, even though Dr. Major did emphasize its importance in that, or for complex patients. Understand that we cannot diagnose as dentists, and physicians are the ones that have to diagnose sleep disordered breathing, whether we're talking about obstructive sleep apnea or upper airway resistance syndrome. Even if a patient we think is just snoring, we still have to be able to have them tested with a sleep study, and then be aware that they don't have sleep apnea before we treat them for just snoring. Okay. Sleep appliances would fall under this, obviously. We do consider sleep appliances to be custom titratable appliances, and they are in throughout the guidelines called mandibular repositioning devices. And what makes a person qualified? Well, the association will come out and decide what that is. Obviously, we believe our program will match, if not exceed, all of these educational requirements. In the guidelines, there's a whole list of exactly what is necessary. We can go through the minimum requirements here, but essentially, this one tells us what we need in the multidisciplinary team, the documentation we're required to have before we provide any treatment, regardless of whether we're looking at, pediatrics, adult, snoring, apnea, upper air resistance syndrome. And then one of the most important things noted in the guidelines that separates us from several of the other provinces is we are allowed to own, dispense, order, use the home sleep testing devices. And this is really important because it makes our ability to communicate with our colleagues in medicine much more clear, and we can give them much better information and make the treatment process much more streamlined. Be aware that if you provide any treatment for a patient, that you do have to provide ongoing monitoring. So essentially, the moment you start treating the patient, you are tied to the patient, either directly or by referral. And as Dr. Major noted earlier, all pediatric treatment for sleep disordered breathing, not just for obstructive sleep apnea, must be done with a full specialist team. Also be aware that we don't know whether the college will require testing for evaluation of dentists to see whether we're competent, but we are required to show that we are continuously updating our knowledge in this ever-changing field. So really, really important. Just make sure you stay within your circle of treatment. And I know I've gone through a lot of this material really fast. In the course that we have with U of A, we will be going into how to make sure we follow these guidelines of treatment in much greater detail. We can open up everything to questions now for everybody.
Do you want to address any of you from the panel Lois's question?
I can go for that one because I said I will deal with that. Basically, Lois's questions, for those of you who might have joined later, was once treated, is life expectancy and all other aspects of our lives back to normal? That's a very, very good question, Lois. If you asked me that about 7 years ago, I would have said yes. But now there is this big trial that was done a few years ago. It's called SAFE trial that is very well known in the sleep community. It was a longitudinal study that followed a lot of patients that went through CPAP therapy and just simply looked at whether or not their life expectancy was better and did it actually decrease the level of cardiovascular events. And these are the people, again, I want to be very clear, that were using CPAP. They were not necessarily fully compliant. The compliance was utilized as 4 hours per night and I believe 4 days or 5 days a week. Unfortunately, the result was not very favorable for the CPAP community. So is it definitely going to decrease your risk of having heart attack? Well, As of today, based on the research that we have, there is no evidence for it. There is no evidence of otherwise. But that being said, in terms of quality of life, in terms of reducing the sympathetic tone and a lot of the inflammatory factors of the disease, in terms of impacting diabetes, high blood pressure, depression, anxiety, yes, there is a lot of evidence that shows that we can improve people's quality of life and their medical conditions once these people get treated. But what I can tell you for sure, it's you definitely are making things not deteriorate as fast as it would have otherwise. You may not be able to get them back to where they were before, but you're definitely preventing it from getting worse. You're minimizing the risk factors. But for me, the most important thing is quality of life for a lot of these people. And that's what we tend to look at in the sleep community more and more. Is it going to make your patient feel better, have better energy, and have a better quality of life on a day-to-day basis? And I can tell you a lot of patients, that's what they're concerned about. They're not really concerned about whether or not they're going to live 10 years more. They want to make sure, even if they're living another week, and of course I'm generalizing here, they want to make sure that next week that they're living, they're going to be feeling good during that time. And that's one of the things I really enjoy about dental sleep medicine, is how you can actually change the way they live on a day-to-day basis. So a great question. I absolutely love that. Hopefully that answered the question there, Lois.
Can you see the second one there as well, Sharsh?
Yes. Yeah, I can look at the questions actually. Why don't I do that to make it easy? The second one asks, anonymous attendee, how do you find a level 2 dentist for sleep apnea for kids? I'm not really sure what that question means. I guess if you're referring to somebody that is treating kids for sleep apnea, that's what I can get. If I'm mistaken, please put a comment or let us know. I believe there are different people in town. Of course, Dr. Major is well known. His practice is focusing on that. If you want to make a comment on that, Michael, by all means. I'm assuming that's what the question means, unless somebody else is reading it differently.
That's what I'm assuming as well too. I think if you go back to the guidelines, the only parameter that's really totally set in stone by the college at this point is they do want a specialist to be treating pediatric sleep. So whether that's an orthodontist, a pediatric dentist, or an oral surgeon, they want it to be in that wheelhouse because of the layers of understanding of what's required with the growth and development that's happening concurrent with the sleep treatment. I don't know of any registry that is being provided in this regard. I know that I think your best bet is to reach out to some of the specialists, probably orthodontists that might be in your area that you'd work with, and ask them if this is an area that they understand, if this is an area where they have training, and using your level of knowledge even to sound out a little bit about where they're at. If you have more questions, feel free. We can have some dialogue here too, some things you may want to ask the people you work with to gauge whether the person you're going to be working with would have a qualified knowledge.
There's another question from Ken Miller. I think there is two questions. One is asking about insurance coverage that was put it in the chat area. And then there is a question about if a patient does not want to wear a CPAP or an oral appliance, what surgeries or other treatments can be done? Great question. And if I can add to that, there are patients that they cannot tolerate CPAP even if they try to, and appliance is not going to work for them. There is a range of surgical options, of course, available, including MMA surgeries, maxillomandibular advancement surgeries. There are surgeries as simple as soft tissue surgeries, such as UPP surgeries. They each have their pros and cons, and patient selection and treatment planning becomes very important. There is, of course, hypoglossal nerve stimulation. That is basically an implantable stimulator of the hypoglossal nerve with the protruding branches that gets the tongue out of the way, the genioglossus. There is a series of surgical treatments that are available, ranging from simple ENT surgeries for making the airway better, all the way to very comprehensive, as I said, maxillomandibular surgery, craniofacial surgeries, which tend to be very effective in some patients as well. Aside from even surgery, CPAP, and oral appliances, of course, there's other treatment options available as well. There's a lot of new treatment options that are coming in the market. There's a lot of what I like to call more early stage treatments, including even proper craniofacial development that is perhaps not as well researched, but it's growing over the next few years, and we're probably going to see more and more solutions. Bottom line is there are solutions available for these patients. Some of the other procedures that we do in our clinic, for instance, is utilizing cold laser for creating more firm tissues in the back of throat, in the upper pharyngeal airway, called NightLase treatment. So there are a lot of options available. With regards to the insurance coverage for this treatment, as of today, the treatment of sleep apnea is considered a medical treatment, which means that any kind of coverage issues should get submitted to medical insurance. It really depends on their supplementary insurance, whether they have, for instance, Manulife, Blue Cross, whatever it is, and depends on the province and where you are. But there is some coverage for these treatments, of course, and it could cover as much as 100% of the treatment cost as well. So hopefully that answered the question, Ken. I believe there is...
Sure. Just before we get into any of the next ones, Brandon, can you pop on? I think you've got a little survey question, so we can continue to answer these, but we want to do a live survey just so that these guys' points are qualified as a live CE session. So Brandon, if you want to go ahead with a little bit of your content side of it, and just in case anybody has to jump off, we're going to keep going while you guys still have the energy to do so. So thank you, Brandon.
So you're going to see a poll here. How interested are you in diagnosing and treating obstructive sleep apnea on your patients? Not interested, interested in diagnosis only, and interested in diagnosis and treatment. So if you want to answer that, I also want to let everyone know while you're putting in your poll there, from CDE side, we want to hear from all of you. Thanks for attending tonight, but we also want to know kind of what courses and things you're looking for. So I put into the chat a link to a form where you can just submit courses or programs that you'd really like to see through CDE. And if you do that submission, all the submissions will be entered into a draw for $100 credit for one of our courses that we'll arrange with you. So we'd love to hear from you about kind of what you want to see and what you want to know going forward. And so I'll close this poll in a minute and check the chat for that link to that form. It's just your email name and the question about what you want to see from us, and maybe adding some extra stuff in there. So let us know. And I'm just going to share the results of the poll here. So we got 53% interested in diagnosis only and 40% interested in diagnosis and treatment.
I don't know how we missed that other 7%. That's on us. If you didn't do it by now, that's just bad. That is just bad. Michael, you could have done a better job there, my friend.
Yeah, I guess I'll shoulder the blame.
Yeah, I think it was because Enoch was late a little bit. That's all.
Oh yeah, sure. Thanks, guys. I work later than all of you, so.
So Lois made a comment. He said, "Thank you. I can speak to the impact of treating sleep apnea in all ages within my own family, including my own kids." And I agree. I wear an appliance myself for over a decade now, and again, I had the pleasure of treating many patients, and I can tell you, it is incredibly rewarding. There is a lot of things that you can do in dentistry, and a lot of good things, you know. Helping people with their pain, helping people having a better chewing, helping people having even better denture, which are really, really life-changing treatments. But what I can tell you is I've never experienced as much enthusiasm from patients that I've seen in the sleep apnea patients. I had a patient actually as late as even today, this afternoon. This guy comes in, he's had an appliance for many years, and he got a new one. He's had some issues. But anyway, my assistant asked, "So how's it been and how's it going?" This is the 1-month recall. And his answer was, "If it wasn't COVID, I would have liked to get up the doctor, hug him, and give him a kiss." It's not the kind of response that you would usually get from another 30-year-old man, 35-year-old man, telling that they want to get up and give you a kiss because you've done an occlusal filling, for instance, for them. So it is very rewarding. And again, when it comes to, so it is something that I highly, highly, highly recommend everybody get involved, because it's not as complex and it's not as complicated as it may sound either. I know we talked about a lot of complexities, but it can be simplified, and that is the whole intention of this program, to make it so easy that any dentist, aside from the 7% that have no interest, for the rest of you who are trying to get into this, it could be as simple and as predictable of everything else that we do in dentistry. Hopefully that answered the question. There is a question here on with regards to independent RDH. This is from Miranda. It says, independent RDH refer for all things beyond our scope of practice. I often refer to ortho when I see signs of a sleep disorder. My question is, legally, like the DDS, do RDH have to follow through the process of care? That's a very good question. That one. That's a very good question. Enoch or Michael, do you guys want to take a lead on that one?
Why don't you take this?
Yeah. So once you make a referral, if you're not providing treatment, your job is done. So as a hygienist, so long as you've screened and you've sent an appropriate referral, you don't legally need to follow up with the patient. It'd probably be a nice thing to do, but at the very least, you should make sure that the referral went through and whoever you're referring to did receive your referral. But in terms of following up on how effective the treatment was, that's not your responsibility. You do not have to document to follow that up.
If I could add a little bit to that, as Enoch said, there is legal and then there is general practice as well. It's good. It's good to follow up, see what your patients go through. For instance, even when we refer patients for CPAP therapy from our clinic, we always bring them back in 8 weeks or 10 weeks, because at the end of the day, you refer the patient to another clinician, in my opinion, and they're going with your trust and your recommendation. So, and you'll get a lot of good feedback in that sense because you want it. But legally, I don't believe it's basically on the person that you refer to in general. There is another comment here saying we do both. It's from an anonymous attendee. It says we do both combined ortho and MMA for cases which failed, and we get great results. And I can agree with that. MMA surgeries can be an amazing resource for some of these patients if done properly. So don't look at this as, again, CPAP versus appliance. It's patients with sleep disorder breathing. How are we going to be managing these patients for the rest of their life? The one thing that is different about a sleep is it's not a one-time treatment. You're managing a chronic disease, which means that you're going to create that relationship with these patients for the rest of their lives. So at some point, it could be an appliance. At some point, it could end up being in CPAP. And at some point, the same patient may end up throughout the surgery as well. So thank you for that comment. Let's see, what else do we have here?
There's a couple more in the chat.
Yeah, it's in the chat. It says, this has been excellent, and I would love to be expanded upon. Thank you so much, Lois. We really appreciate that. Glad that you find it useful. And thanks again to the university team to putting this together. We really, truly appreciate that. I would like to learn how to diagnose and what to look for anatomically. That is from Mary. And I'm glad you brought that up. Those are some of the things that we'll be covering through the program. I don't want to get into a lot of detail. Maybe James, you can even comment on that one. It is going to be one of the most, I don't want to say the most comprehensive program that is available, but it is going to be extremely comprehensive. We're going to be bringing on great guest speakers from different disciplines, ear, nose, throat specialists, sleep specialists, psychiatric specialists, pediatric specialists, bringing the cadaver lab into the program. So it gives you guys a great understanding of what the disease really is. Just like anything else that we do in dentistry, understanding the normal and the pathogenesis and the physiology behind and what normal should be is going to help us a lot with actually being able to provide that good treatment. So it is going to be an extremely comprehensive program. Going through that is going to give you a lot of knowledge that you should be able to help many patients in your practice in that sense.